Hi, welcome to this virtual tumor board. I'm Dr. Benjamin Levy. I'm an associate professor at Johns Hopkins School of Medicine and the clinical director at the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital in Washington, D.C. We have a wonderful panel today, a multidisciplinary approach discussing 9 cases. We'll start with introductions, and Dr. Force, if you want to start.
Sure. I'm Dr. Seth Force. I'm the Kamal A. Mansour Professor of Surgery and Chief of General Thoracic Surgery at Emory University Hospital in Atlanta.
Thanks, Dr. Force. Moving around the Zoom room, Dr. Kamich.
Hi, I'm Dr. Ross Camage. I'm the Director of Thoracic Oncology at the University of Colorado Cancer Center. I'm a medical oncologist where I hold the Joyce F. Chair in Lung Cancer Research.
Great. Next, Dr. Higgins.
Hi, I'm Dr. Kristen Higgins. I'm a radiation oncologist. I specialize in thoracic malignancies at Winship Cancer Institute of Emory University.
Great. And rounding us out, the radiologist, Dr. Keys.
Hi, my name is Dr. Darren Keys. I'm a diagnostic and interventional radiologist for Piedmont South Imaging, covering Piedmont Fayette Hospital and Piedmont Noonan Hospital, south of Atlanta.
Great. Dr. Force.
So this is a 73-year-old gentleman with a significant smoking history who had a history of a right upper lobe lung nodule, but he was kind of lost to follow-up. So this had been seen on previous imaging. He then presented to an outside emergency room with chest pain, and he had a CT scan that showed a 5-centimeter spiculated right upper lobe lung mass and then an enlarged right paratracheal lymph node.
Okay.
So his medical history is significant for stage 3 chronic kidney disease, hypertension, and COPD. He has a 51 pack year history of smoking, and he had quit 2 months prior to his presentation. No significant drug or alcohol use, and no significant family history. So Dr. Keys will take over.
Here we have 2 axial PET-CT images. The image on the left demonstrates a very intensely FDG avid mass in the anterior part of the right upper lobe. It's abutting the pleura. There may be a portion of it abutting the mediastinum as well. The image on the right shows a very intensely FDG avid lymph node in the right paratracheal space, just at the level of the hilum. So these findings are most consistent with a primary lung cancer that has metastasized to that lymph node.
Okay. Dr. Force.
So he had a brain MRI that was negative for metastatic disease, and he underwent a bronchoscopy with biopsy of his mediastinal lymph nodes. And it's important to mention that we don't just biopsy the lymph node that's lighting up, we biopsy all the mediastinal lymph nodes to make sure that he doesn't have multi-station metastatic lymph node disease. So the lymph nodes were biopsied. That one was positive for cancer, suggesting single station stage 3A non-small cell lung cancer. You can see his PFTs there. Again, his FEV1 was fairly good at 71%, pretty diminished diffusion capacity at 43% of predicted.
Great.
So we presented the data to him, and since he did have single station lymph node disease, those patients we will often offer combined therapy, so neoadjuvant or treatment before surgery, followed by surgery, assuming they have a good response to neoadjuvant therapy. It still is not a guarantee of good long-term survival. When he heard the statistics, he chose not to go with surgery, and so he went with definitive non-surgical therapy or chemotherapy and radiation.
And it looks like he got radiation 60 gray, and he got consolidation durvalumab as well, post-radiation, correct?
Correct.
Okay.
Well, let Dr. Keys take over again.
So here we have multiple PET-CT images through the lungs and the upper chest. And these are at different time intervals. I presume the 6 month at the top, 10 months in the middle, and 16 months at the bottom. What you have at the 6 month mark, where there was once a very well-formed mass, it's a little bit more ill-defined. That can often be seen following treatment. And there's also some area where that lymph node used to be, it's much smaller. So you're seeing a response to therapy. And again, some of the stuff in the lung apex could just be treatment change. At 10 months, you see the area is becoming less FDG avid and more organized. And this is, what you hope to see after treatment, though there is still some FDG avidity in that residual mass in the upper portion of the right lung. The lymph node region now looks completely negative. And then at 16 months, you're left with a persistent FDG avid mass in the upper portion of the right lung, and again, a negative paratracheal node basin.
All right, what a difficult case. You've got what appears to be a local recurrence, post-concurrent chemoradiation, and 1 year of durvalumab. I think this is emblematic of a multidisciplinary discussion because it may involve all three disciplines to best decide on how to treat this patient. This patient decided against surgery the first go around, but was a surgical candidate. So I'll start with Dr. Forrest. This is your case. Is there a role for resection of this lesion or removal of it for cure?
There is. You know, even though the time frame of neoadjuvant therapy to surgery would not be the standard course, he did, you know, at least have a good response in his mediastinum. His options for the primary lesion are pretty limited at this point, and surgery is definitely an option for him.
All right, Dr. Higgins, dare I say protons, but is there a role for other radiation options? He's gotten definitive radiation. Is there a role for reirradiation?
So whenever we're dealing with a local only recurrence, no evidence of any distant disease, in the presence of recent radiation, we would look for surgical options first to avoid excess toxicity from reirradiation. If there's not a surgical option, then yes, we will consider retreatment with radiation. When we do retreat, we would prefer to use proton therapy because you can really reduce the exit dose of the proton beam in the tissue, so you lessen the lung that gets more exposure to the radiation. But certainly there's a much higher risk of high-grade toxicities with this approach. So really, if there is an opportunity for a salvage resection, that would be my choice.
So Dr. Kamich, let's say this patient doesn't want surgery the second go around, didn't want it the first time. Dr. Higgins feels strongly that, you know, there may be too much toxicity with a reirradiation approach. How do you approach a patient like this? One of the most contentious areas for medical oncology, how to manage patients who've received concurrent chemoradiation with consolidation durva who have recurrence, in this case, a local recurrence, not amenable to surgery or radiation.
Well, so let's make an assumption that we've rebiopsied this and confirmed that this is a local recurrence and not some inflammation for some other reason. I mean, I think you'd want to sit down with the guy and say, look, you're driven by the data. You weren't concerned that, you know, you didn't want to do surgery because of the data. If I put you on some kind of systemic therapy, it's not going to cure you. You have a chance of re-cure by these other guys. But if he still sticks to his guns, you know, we're committing someone to kind of long-term therapy. I think I'd want to go back and say, look, have they really looked hard for an oncogenic driver? Yeah. I think our list of things we can look for expands. So I just want to check that there's something other than chemotherapy we could do, but otherwise he's looking at chemotherapy.
Yeah. Would you offer immunotherapy with chemotherapy given that the patient has already received durvalumab?
Well, so the impression is, so let's assume he got durvalumab to 12 months. So this is progressing maybe 4 months after the end of the durvalumab. I would be very surprised if that was transformative.
Okay, very good. A great case, and one that we see quite commonly in our tumor boards on how to manage, and it really does involve all three disciplines to best manage these patients and a real shared decision making with patients in the absence of data.